efficacy and mechanisms of action of SSRIs, lessons learned from premenstrual dysphoric disorder and depression. Elias.
Thank you. Okay, first of all, I would of course like to thank ECMP for this unexpected award, which I did not expect at all, and also for the chance of giving this lecture, which I look forward to do. These are my disclosures, not so many these days. And I would also like to emphasize that I'm an old-fashioned guy, so the drugs I will talk about today in this history lesson is clomipramine, SSRIs and SNRIs, and they are all since long off patent, so they are of zero interest to the big pharma, unfortunately I would say, but that is the case. Some of you may have seen this paper. It came 2 years ago, where some of the in the anti-psychiatric camp claimed that now we can forget about the chemical dysfunction in depression, and serotonin is absolutely not abnormal. It was a so-called umbrella review by Moncrieff and co-workers. It was effectively rebutted in several papers I saw, but nevertheless it was very much received with enthusiasm in the social media and in newspapers and in the anti-psychopharmacology camp. What they did was as you know, since we have no ways of really, in a sophisticated way, measure serotonin activity, people have throughout the decades tried something else to get some insight into the function of serotonin brain. Platelets, serotonin markers, or certain gene variants and so on. But none of these methods, of course, can be regarded as a perfect way to measure serotonin activity. And since then, they didn't claim that there were no consistent patterns. They said serotonin is normal. And let me just, this is obvious for such a qualified audience as the present today, but let me just emphasize that the justification of the use of SSRIs, of course, has never been that serotonin is known to be depleted in depression. It has even not been that we know that these drugs inhibit serotonin, the serotonin transporter. The only justification is that the patients are suffering and in need of treatment, and that SSRIs do work and are tolerable. So from a treatment perspective, the umbrella review was totally irrelevant, I would say. I would also like to give some, especially at a congress like this, one gets very happy to see all these young researchers, many of doing different kind of work. And I would just like to describe what I regard as the three paths three strategies in modern psychopharmacological research. We have old school psychopharmacology. That is, of course, and this is here illustrated by the three principles of serendip. This is always started with a serendipity finding, and then certain drug is unexpectedly shown effective for a certain condition. Then pharmacologists try to understand how this might impact serotonin neurotransmitter effects in brain or other aspects. And then new drugs are constructed, being similar but also somewhat dissimilar to the previous ones, and they are tested in trial and error fashion. So this is in fact how all modern psychopharmacological drugs have been come to be. And then we have, of course, the preclinical exploration of how brain neurotransmitters impact certain behaviors. And here we have more or less sophisticated behavioral models, but we also these days, of course, have an enormous explosion in technology thanks to the inventions of molecular biology. So now, as you know, we can turn on and off neurons with optogenetics or chemogenetics, and we can study the entire transcriptome in individual neurons and so on and so forth. But this is usually not focused on drug actions, but more trying to elucidate the basis for various kinds of behavior. And finally, we have, of course, the search for measurable differences in transmitter function between patients and controls. And here we still we have today much more sophisticated models as compared to when I started in this field of research. GWAS studies and advanced MR techniques that could study the connection between different brain areas, and sophisticated PET techniques, and so on and so forth. When it comes to the use of SSRIs in depression, it has been entirely the result of old school pharmacology. Then interesting data have emerged elucidating some aspects from preclinical exploration and for the search for measurable differences, but it mostly entirely based on old school pharmacology. Now, it was indeed one study here, just 1 year after the umbrella paper by Moncrieff, in fact, describing evidence for a reduced serotonin release in depression in frontal cortex. Let's see if this can be replicated, but one never knows. Interesting it is. So I have introduced also, because of all the young people here, a very brief history lesson. Why do we have the SSRIs? And it all started in 1950 in December at Rouen-Poulin, when Charpentier and Courvoisier synthesized and tested a novel antihistamine, chlorpromazine. That was the start of everything. And then, of course, the surgeon Henri Laborie, who was interested in pre-medication before surgery, tested chlorpromazine along with other antihistamines and thought this was kind of special. So he suggested this to be tested in psychiatry. And then, of course, Delay and Daniker in Paris. This was a major breakthrough for modern psychiatry. In 1952, they reported chlorpromazine to be effective for schizophrenia. And then the Swiss company Geigy wanted their own antipsychotic, and since no one at that time knew how chlorpromazine works, they modified the molecule somewhat and created the molecule imipramine. And they asked a psychiatrist in Switzerland, Roland Kuhn, to test it for schizophrenia. He found it to be totally inactive, but he also found it to be antidepressant, because he also gave it to some depressed patients. And no one knew at this stage how this drug works, but then Julius Axelrod, the famous Nobel Prize winner from US, showed that this is an inhibitor of the reuptake of noradrenaline. And then that led American psychiatrist Joseph Schildkraut in a famous paper from '65 to suggest that depression may be due to noradrenaline deficiency. And then we had Alec Coppen from England suggesting that also serotonin could be involved. And then Arvid Carlsson in 1968 showed that imipramine, in fact, also blocks the reuptake of serotonin, and that could indeed be the mechanism of action. And what he also found was that one of the tricyclics that he tested, clomipramine, was even more effective on serotonin. And I will come back to that drug shortly. So that was a real forerunner, one could say, of the SSRIs. It's quite SSRI-like. And then Arvid went to Astra Pharmaceuticals in Sweden and suggested that they should develop a selective serotonin reuptake inhibitor. And they did develop the first such drug called cimelodin that unfortunately was withdrawn because of side effects, but it was before that shown to be effective in depression, to a proof of concept of the serotonin theory. And then, of course, came Prozac and the other blockbusters, SSRI blockbusters. And then finally, in the 70s, 80s, 90s, clomipramine and SSRIs were quite unexpectedly shown effective also for a number of other conditions. They were developed for depression, but they were shown effective for OCD, panic disorder, premenstrual dysphoria, social phobia, generalized anxiety. And I will talk a little bit more about premenstrual dysphoria and panic because we worked with that. So this is a history of why we have SSRIs. So I have shown this before, but I said that the proof of the pudding here is that the SSRIs do work. And now again, we have the critics. And as you all know, the critics claim that they do not work. And here are some of these guys that have gained enormous attention. Professor Peter Goetsche, this is his book. It's not from Scientology, you could believe that, but it's from him. Deadly Psychiatry and Organized Denial. Then we have Jean Moncrieff, threw away the antidepressant, urges leading scientists. We have journalist Robert Whittaker, and we have, of course, Irving Kirsch, who claims that SSRIs are no better than placebo, and if they are better, that is just because of the side effects breaking the blind. So, and they have had an enormous impact, not only in media, but also on authorities in many countries that now argues that, well, for moderate and mild depression, SSRIs should not be first line of treatment anymore. So I plan to talk here about why are the SSRIs effective in depression and other indications, but I think I first must discuss the question, are the SSRIs effective in depression and other indications? If they are not effective, the last part of my presentation should be redundant. So I would like to start with this, and we have looked further into this controversial issue, the antidepressant controversy. And all this started, of course, with a meta-analysis from Kirsch, but also from other groups, where they had looked on many SSRI versus placebo trials from the drug companies, and both published and unpublished, both positive and negative, and their conclusion was that there were almost no difference between placebo and SSRI, and if there was an effect, it was only in the most depressed patients, and then it could be a matter of side effects breaking the blind. But there are considerable methodological problems with many of these meta-analyses. One is that they are trial-based rather than patient-level based. And if you want to, for example, study the relationship between side effects and response, or baseline severity and response, you obviously need to do it on patient level, not on trial level. So that is a considerable problem, I would say. Also, they have taken for granted that all doses are equally effective, so they have included also what I think is suboptimal doses, which of course may lead to an underrating of the actual efficacy. They have also lumped together drugs from different classes, assuming that all antidepressants are the same. For example, in the Kirsch review, they had a lot of studies with nefazodone, which is neither typical SSRI nor SNRI, a rather strange drug that is withdrawn and was probably not as effective as the other ones. And they have based their evaluations on the intention to treat, last observation, carried forward, handling of dropouts. And that is, of course, unfortunate when you have drugs causing side effects leading to early dropout, because then you use the symptom rating maybe after 1 week as an endpoint result, which obviously does not do justice to the drug. And also, and maybe the largest problem, they have assessed efficacy outcome using a questionnaire measure of depression severity. In most of these old trials, it was the Hamilton Depression Rating Scale. Make no mistake, Max Hamilton, you can see him here, it was a great achievement when he invented this scale back in the 50s. It's a very old scale, but it's obviously not suitable for evaluating efficacy in depression trials. It's multidimensional, which is a problem. It has 17 items, and several symptoms are often absent at inclusion. That leads, you cannot get better than 0, so that wouldn't help in detecting a difference, but it would increase variability and decrease sensitivity. Several symptoms are present also in patients that have recovered or in healthy patients. Normal population does not rate 0 on this scale, but have a certain number of points, also increasing variability. And which is most important when using it for SSRI trials, several common SSRI side effects are rated as symptoms of depression with this scale. Gastrointestinal complaints, loss of libido, weight change, sleep disturbance, and all this, of course, decreases the drug-placebo difference. Needless to say, this could be symptoms of depression, but it could also be at hand in totally recovered patients as a result of SSRI side effects, and I will show you some data shortly. And many people have, since decades back, argued that this is not suitable as a measure. You can see some of the papers here. There is a Danish gentleman, was Per Beck, who at an early stage suggested that one should look only on 6 core symptoms of depression rather than the entire scale. And here Søren Østergaard and co-workers used this strategy on the STAR-D. Everyone knows about the big US STAR-D study, and found indeed that the remission rate and response rates were considerably higher if you looked on the core symptoms rather than use the sum score of Hamilton points. So we have what one could call the Gothenburg antidepressant post-hoc project, where we have exposed a lot of clinical trials in this field for a post-hoc analysis, trying to evaluate the true efficacy of the drugs and to see if some of the criticism may be founded. I think one should not ignore this kind of critics. I think one should discuss the data. And in all these, we have included all relevant trials, negative as well as positive, published as well as unpublished. All our trials are, we have not assumed that all antidepressants are created equal, so we have studied them separately. We have not assumed that all doses are equally effective. We have used mixed modeling, which is a modern way of handling dropouts rather than ITT, LOCF. And we have assessed impact on specific items rather than on the sum score of the Hamilton Depression Rating Scale. And most importantly, what I forgot when I made this slide, is that all these trials are on patient level, not on trial level. So to that end, we got patient-level data after some discussions regarding all relevant studies with sertraline, paroxetine, and citalopram from the development programs. And also we got duloxetine data from Eli Lilly. So Pfizer, sertraline, GlaxoSmithKline, paroxetine, Lundbeck, citalopram, and duloxetine from Eli Lilly. And I will now address some of the claims made by those questioning the efficacy of these results. First, they say that SSRIs have failed to beat placebo in half of the studies. And this is a paper by Fredrik Hieronymus and co-workers that we published some years ago. And when we first looked on all relevant comparisons with respect to the normal efficacy parameter, that is the sum score of all the Hamilton items, we found that less than 50%, only 45% or so of the trials revealed a significant superiority of the SSRI. That is lackluster. That is kind of disappointing. But we instead looked on what is arguably a key depression symptom, depressed mood. Almost all trials did detect an antidepressant signal, showing that this normal effect parameter is much too insensitive to catch an antidepressant effect. And the reason for this large difference is, of course, that we have a low effect size for the sum, a high effect size for depressed mood, and then lower effect sizes for symptoms that are not as prominent, not as common at baseline. And especially, we have very low or even negative effect sizes for the items that are also SSRI side effects, such as insomnia, such as gastrointestinal problems, such as sexual dysfunction, such as loss of weight. All that can be caused by the SSRIs, and that is why the outcome with the HDRS-17 becomes so poor. And then we have also, in a study by Hieronymus again, also compared rating with side effect data, showing that patient reporting a certain side effect that also impacts the rating of that symptom, such as gastrointestinal problems, for example. So we don't agree with this criticism. Then we have the claim that no dose-response relationship has been demonstrated, that the dose-response curve should be flat for these drugs. For example, a opinion leader, Marcia Angel at Harvard, she was previously editor-in-chief in New England Journal of Medicine, and she often writes, often quite good, I think, in New York Review of Books. She had some very anti-psychiatry papers in that journal, and she was very impressed, obviously, by the work of Irving Kirsch. She bought into that entirely, and she said, Kirsch reported a number of other odd findings in clinical trials of antidepressants, including the fact that there is no dose-response curve, that is, high doses work no better than low ones, which is extremely unlikely for a truly effective drug. One could agree that that would be extremely unlikely, but it is not true. We have here studied different SSRIs, and there is a clear-cut dose response. Citalopram 40 is better than citalopram 20, which is better than placebo. Paroxetine 20 is better than 10, which is better than placebo. Sertraline 100 is better than 50, which is better than placebo. If we lump together optimal doses with suboptimal doses, as we have done to the right, we have a clear-cut significance with respect to high versus low dose, both with respect to the sum of the Hamilton scale and with respect to the depressed mood item. So and then it was a trial-based analysis from Cipriani or from Furukawa and co-workers, where they found about the same numbers that we did when it comes to optimal doses. So there is a dose-response curve, so this argument is also not, I think, very valid. Then we have the claim that if they do exert an effect, this is too small to be of any clinical relevance. And Kirsch often points out that the Hamilton scale is graded from 0 to 52, that is a maximum. And the mean difference between treatment groups is often about 3 points. And obviously 3 points on a 52 graded scale cannot be clinically relevant. But we don't agree, again. First, one should emphasize that depressed patients usually have far less than 52 points. 18 points are usually a cutoff for moderate depression. And non-depressed patients, as I said before, don't display 0 points. They may have back pain or gastrointestinal symptoms or poor sleep or something that gives them some points. So in fact, the scale is much more narrow than you can read out from Kirsch's writings. And then, as I said before, differences in the sum score underrate the actual effect because side effects, SSRI side effects in particular, contaminate the scale. And then a mean difference of 3 points, of course, does not mean that all subjects improve this modestly, since active treated groups include both responders and non-responders. We have looked further into this, but I cannot present these data today for the sake of time. But so it's not that everyone gets 3 points better, of course. We wanted to look at effect sizes, and this is just the paper I just mentioned before, where we tested the different doses, again with Fredrik Hieronymus as first author. And here you can see that when we compare, take away the suboptimal doses, compare placebo with optimal doses with respect to the key symptom depressed mood, then we have a effect size of about 0.5, which is normally regarded in medicine as a medium effect size, not that bad. And this is a nice paper by Leucht and co-workers showing a number of effect sizes in somatic medicine and psychiatry. And psychiatry doesn't come out too bad here. And this is where depression would be if we use the sum of the Hamilton scale, and this is where we are with the depressed mood item and also with the Beck item and so on. So Beck subscale and so on. So it's not too bad. And then one should remember that there is a huge difference, of course, between depression trials and studies in, for example, hypertension or high lipids or something like that. So that because that will reduce the likelihood of finding large effect sizes. There are no objective inclusion criteria in depression trials, no objective and exact effect parameters, poor compliance in other fields of medicine, larger dropout rates in other fields of medicine, spontaneous remission and regression towards the mean leads to improvement also in placebo groups. And these days, only treatment-resistant patients have an incentive to participate, so they are often difficult to treat patients joining this kind of trials. And in fact, but nevertheless, we have a kind of, I think we can skip that one, kind of fairly good effect sizes. Then, if they do exert an effect, it's only in those with very severe depression, it's often stated, and we studied that as well in this paper, again with Fredrik Hieronymus, and what we see here is on the Hamilton scale, the sum rating of all the items, it seems that if it's a somewhat better effect in severe cases as compared to moderate cases. But if you look on the key depressed mood symptom, there is absolutely no difference. They are as effective for reducing depressed mood in the moderate group as in the severe group. And if we look on the Beck subscale of 6 core depression symptoms, exactly the same outcome. But when we look on the non-Beck symptoms, the other symptoms, we have absolutely no effect in the moderate depressed group. And that is because the reason why people are categorized as severe depression is that they have a lot of points, meaning they have a lot of symptoms. Patients can be characterized as moderate depression while having a lot of depressed mood, suicidality, anxiety, but they don't have the other symptoms, the non-Beck symptoms. And if they don't have those symptoms, they won't respond to those symptoms. And on the other hand, side effects may increase the rating of some of those symptoms. So this is kind of a statistical artifact, and the truth is that in moderate depression, they are just as effective as in severe when it comes to reducing depressed mood and similar symptoms. And so in a CBS broadcast with Irving Kirsch, I said authorities have been impressed by Kirsch, and here we had a representative of NICE in UK, Tim Kendall, and he said, we came to the conclusion that for mild to moderate depression, these drugs probably weren't worth having. And Leslie Stahl, the journalist, said, not at all. Not really, said Kendall. I think that was premature. I think they have a role to play also in moderate depression. Okay, and then claim 5. If they do exert an effect, this is second to side effects breaking the blind. The idea here is that if you feel that you are not on placebo, you have some side effects, and you realize this must be the active drug, then you have an augmented placebo effect. That has also been suggested by Klein and co-workers. It's a very popular theory. And there were some early trials, especially this one, showing that for some fluoxetine trials, in trials with a lot of side effects, the patients also responded well. I think that is a strange way to investigate in this. I don't see a reason why patients should have more side effects in one trial population than another trial population. So this clearly should be studied on patient level, I think. Then there was a much larger and better study, but still on trial level, that examined this, and they concluded that our results do not support, but also do not unequivocally disprove the hypothesis adverse events lead to an overestimation of the effect of SSRIs over placebo. We studied this in this way, that we looked at adverse event reporting and compared patients without any side effects with those on placebo. And if this theory was correct, we should see no difference. But as you can see, we do the citalopram and paroxetine outperforms placebo also in patients with no side effects. In citalopram studies, there was even a bit larger effect, it seems, in those without side effects. This is the depressed mood, so it's not contaminated by side effects. In paroxetine, it was somewhat better effect in those with side effects, but still a significant difference here. The fact that we have somewhat more effect with some more side effects could, of course, also be a dose question or a pharmacokinetic question. If you have higher levels in blood, you may have both a better effect and more side effects. But the important thing here is that, yes, we do indeed see differences also in patients without side effects. I think we skip this because of sake of time. So I don't buy into this argument also. Finally, it has recently been studied, oh yes, there might be an effect after all, but this is secondary to a general blunting of emotion. You cannot be sad but not also happy with these drugs. And that is a phenomenon that definitely happens. I think it's a side effect that should be acknowledged, but it's difficult sometimes to separate from depressive symptoms. But in the Montgomery-Åsberg depression rating scale, there is in fact an item called inability to feel. And if this theory that the improvement in mood was always secondary to emotional blunting, then the inability to feel should be worse and the depressed mood better. But what we find in this paper is that we have a beneficial effect both on inability to feel, that is more ability to feel, and a reduction in sadness. So it couldn't be the first leading to the other. And the effect size for both were about the same. And exactly the same results were reported by some other workers studying bupropion and some serotonin reuptake inhibitors. So we also don't believe this. So finally, we think the criticisms claiming that these drugs are not effective can be rebutted. But I would also now, leaving this topic, but also mentioning some other aspects that one could study in let's check the time, that one could study in this kind of item-based analysis. And one is when do the first signs of an antidepressant effect appear? And if you take the normal effect parameter, there's absolutely nothing happening after 1 week. But if you look instead on depressed mood, you can see that it starts, you have a significant difference already after 1 week. Here, that is probably masked by side effects. So something is happening already in the first week that is then going on. And this is, of course, compatible with several of the theories regarding long-term effects of these drugs. It could be a regrowth of dendritic spines. It could be a downregulating of hyperactive serotonergic neurons. It could be, as suggested by workers in Oxford, subconscious modification of a negative cognitive bias. It's not compatible with the idea that antidepressants should work by formation of new neurons in hippocampus, because that cannot happen in just 1 week. So I don't think that is the most likely explanation here. Do SSRIs increase risk for suicide at the onset of treatment? That was studied by Gibbons on patient level. They found that venlafaxine and fluoxetine, the net effect was beneficial already after 2 weeks of treatment. We find exactly the same in patients above 24. We see no such effect below 24, but there we have a very marked placebo response in young people. So I don't claim that it cannot be some patients reacting paradoxically here, but the net effect is beneficial. Finally, we have also studied now if there are differences between different antidepressants in terms of efficacy. And you may have seen this very important and nice paper by Cipriano and co-workers in Lancet, ranking the different antidepressants in terms of efficacy. Amitriptyline number 1, meprotylene very close to the SSRIs and SNRIs, but number 2, mirtazapine, and then the SSRIs and SNRIs. Both amitriptyline and mirtazapine, as you know, as many of you know, are strong H1 antagonists, so they cause sedation and they cause weight gain, and that could be the explanation why they come out so nicely when you have the total scores of the Hamilton. So we looked into that, and I will not go into detail here. I will just say that when we look on Hamilton score, we can confirm that mirtazapine is better than SSRI, that is better than placebo. But when we look into different symptoms, it seems that SSRIs, SNRIs are in fact more effective than mirtazapine for depressed mood, suicidality, anxiety, and so on. So mirtazapine is not as genuinely antidepressant. But with the amitriptyline and some other tricyclists, they really seem more effective than SSRIs, SNRIs, and mirtazapine, also with respect to core depression symptoms. Okay, so now I would like to say a few words, my final 8 minutes or so. Why are the SSRIs effective in depression and other indications? And I can skip that one. And I think to understand this better, one should not ignore the other indication. And we have been particularly interested in premenstrual dysphoria. Here, symptoms regularly appear the weeks prior to menstruation and disappear shortly after the onset of menses. They are triggered by the hormonal fluctuations of the reproductive cycle. Irritability and anger are the most prominent symptoms. Severe forms are reported to cause as much distress as depression and to be associated with an increase in suicidal ideation. And it's a relatively high prevalence. And we had some reasons for once testing not SSRI but the forerunner clomipramide here, because which are the dominating physiological impact if you take away serotonin from animals? You can do that with a synthesis inhibitor, with neurotoxins, with lesions on RAF, and these days with knockout of, for example, the TPH2 symptoms. And these are the 4 symptoms they behave fairly normal, but they display more aggression, more sexual activity, more food they take, and less anxiety, these animals without serotonin. That suggests to me that serotonin has as a physiological role to dampen aggression, dampen sexual activity, reduce food intake, and increase fear anxiety. Increase, not decrease fear anxiety. And we have some data here from Näslund and co-workers where we show indeed that anxious rats have more serotonergic activity and they get less anxious if you take away the serotonin. And these 2 first symptoms, aspects of behavior, are clearly also regulated by sex hormones, sex steroids. And so our rationale for testing here many years ago, a serotonin reuptake inhibitor, is that the major role of serotonin appears to be dampen sex steroid-driven behavior, including anger, irritability, and depression. Because premenstrual dysphoria is driven by sex steroid and is dominated by aggression. And this is one of few occasions when even an early open trials convinced me. We had a marked reduction in irritability in these patients with clomipramine, and then we could confirm that in the controlled trials, and about the same time there were also studies with fluoxetine from US confirming the same. Then we had a surprising finding. Some patients told us that, well, we have realized we don't have to take this the entire month. We can just start at ovulation because then we are fine. So we did a study with what we then called intermittent treatment, that is now the approved or recommended treatment here, and we could confirm that you can start treatment immediately at ovulation, and you have a very short onset of action, and then you can stop administering the drug around menses. And here just to show you how a normal woman with PMDD self-rates her irritability, first 2 reference cycles and then on placebo and on citalopram intermittently. And in this study we have compared, we have studied paroxetine, and I would just like to mention that if you focus on the core symptom, disregard the less important symptoms where we have not as good effects, such as bloating and breast tenderness, we have both with intermittent and continuous administration, a very good effect, an irritability of effect size of 1.4, which is quite unique for psychiatry, and always very low p-values. If I would introduce this in the slide by Leucht, it would be here. So this is really an impressive effect. And so what I would now finally like to state is that premenstrual irritability is kind of a poster boy for a serotonin dysfunction syndrome. We have very few non-responders to SSRIs. SSRIs are better than non-serotonergic antidepressants. We showed this comparing meprotylin and paroxetine, and others have shown the same. So here you need to go to serotonin. We have an immediate effect when you have the SERT inhibition. We have also studied the effect of treatment in the midst of the luteal phase, and they have an almost immediate reduction in symptoms. And what about, there are serotonin releasers, fenfluramine and MCPP. These are drugs shifting the direction of the transporter, so they are pumping out serotonin. Do they have an effect in PMDD? They should have, if this has to do with the extracellular levels. Yes, they have. Several studies show that both fenfluramine and MCPP have an immediate symptom improving effect. And then we have also shown by us and by others, by Carl Rickels and co-workers, an effect of the 1A agonist bisbaspirone. And very clearly, here we have a clear-cut symptom aggravation obtained with tryptophan depletion. So this is really, PMDD behaves exactly as you would like from a serotonin deficiency condition. And now I have only 3 minutes left according to this display here. So I would just like to mention that also now a study by Sasha and co-workers, I forgot that slide, but they showed in PET study changes in the SERT binding in PMDD, quite interestingly. This we can skip. Do SSRIs cause an immediate increase in extracellular serotonin? Some have argued that they do not, and this is very recent data, as you can see. I have not prepared a formal slide, but we did cerebrospinal sampling 3 occasions, and we do find in PMDD women that they have the SSRI indeed increases serotonin levels. And in fact, let's go further here. In fact, if you look on also other immediate effects of the SSRIs, they are perfectly compatible with what you find with the serotonin depletion studies in animals. You do get reduced anger and irritability, not only in PMDD, but also with brain injury and dementia immediately after starting treatment. The sexual side effects appear immediately. As all clinicians know, nausea and weight loss comes early, and you have an increase in anxiety in susceptible individuals. We have studied that in depression. Let's skip that. It has been studied in health controls, and particularly in patients with panic disorder. That is very common, that they get more anxious at start. And now I have 1 minute left, 1.5 minutes left. Panic was another condition that we were very interested in. It's linked to respiration, and serotonin is involved in chemoreceptors, so that is one link here. Donald Klein showed many years ago in the 60s that imipramine is effective A co-worker of mine, Kjell Modig, found in his clinical practice that clomipramine at low dose was much better. And again, then we did a clinical trial showing clomipramine to be clearly better than imipramine. As previously shown in OCD by Yossi Sohar, who is somewhere here, I think, and as I also showed in PMDD. Kirsch believes that all psychotropic effects are due to side effects, but that cannot be the case here because all drugs do not work. So what I finally would just like to show you is this comparison, that with panic you have a similarity with PMDD, that it's large, huge response rate, and serotonergic drugs are better. But you don't have an immediate reduction, but rather an increase in symptom. It has also been shown that serotonin releasers increases symptoms in panic. They are panicogenic. I think, I believe the opposite just a few years ago, but I now think that it's quite likely that the anxiety-reducing effect of SSRIs in panic and perhaps also other anxiety conditions are more likely to due to a downregulation of an overactive anxiogenic, anxiogenic impact. So there are some interesting studies suggesting increased serotonin activity both in panic and depression, but I skip those. Let me just summarize with a comparison with schizophrenia. In the 60s, it was shown that antipsychotic drugs block D2 receptors. For decades, critics of psychiatry ridiculed that anyone could be presumptuous enough to formulate a theory regarding the pathophysiology of schizophrenia on the basis of how the brain of a mouse is impacted by a drug. Today, many decades later, there are robust PET-based evidence for schizophrenia being associated with enhanced dopamine release in the associated striatum and at the same time reduced release in prefrontal cortex. My belief is that something similar will happen with serotonin, depression, and anxiety. We will find maybe increased activity in certain brain areas and reduced activity in other brain areas. In fact, we have a grand theory explaining all this, exactly explaining the mode of action of these drugs and how they impact pathophysiology in all these conditions. And I plan to present it to you, but I realize that my time is out, so that will be another time. Thank you.
Thank you very much, Elias. You saved almost 5 minutes for questions, but we got hundreds, so it's going to be challenging. We got a question from Kamala Harris, but none from Donald Trump. I'm sorry.
I'm happy to hear that.
Yeah. And also from Siegfried Kasper and other prominent people in the world.
I'm happy to hear that as well.
Yeah. So some questions had to do with the issues on side effects. I think you actually didn't mean that the side effects are not there. Side effects are present with SSRIs and actually have an impact in real life. Is that right?
Absolutely. I think one must here separate two things: the efficacy of a drug and the tolerability of a drug. When you assess efficacy, which is of theoretical and practical and clinical impact, then you should discard the side effects. And if you let the rating of efficacy be contaminated by side effects, you may underrate the efficacy. Of course, when you discuss the usefulness of the drug, you should separately take into consideration the side effects. And of course, they can be quite cumbersome with SSRIs. So that is my point.
There are plenty of excellent questions. One has to do with, for example, if you think it's also relevant to look into registries and observational data and real-world data to complement information from clinical trials.
On what?
On antidepressants, for example.
Yeah, absolutely, and such things has been done. We are doing a little bit of that. We have, for example, shown that in Sweden, at least, most SSRIs in depression are underdosed. They are never given at the optimal doses. But there are also, for example, with respect to the impact on suicidality, there are nice, huge epidemiological studies confirming that there's no increase in suicidality after onset of treatment, but rather the opposite. So.
Couple more questions. Do you think the field of precision psychiatry and more precisely genetics and pharmacogenetics may hold from some promise in this area?
Everyone hopes so. I don't think it has delivered yet. I don't think that is today any data supporting precision medicine. We are looking into, as many others, if a symptom profile could be helpful, if a certain profile should lead to trying bupropion and another SSRI. There are no strong data on that also, but maybe modeling, machine learning techniques could be helpful there. But so far I haven't seen any quite convincing data.
And you briefly discussed some of the limitations of the Hamilton scale. Would you propose a different scale for measuring antidepressant efficacy?
I think the depressed mood item would be sufficient. In fact, that is the most sensitive. But of course, I think the Beck subscale is better than the total Hamilton. I think Montgomery-Åsberg is better than the Hamilton. So there are already scales available, but they could also be improved.
And do you think that, finally, for premenstrual dysphoric disorder, do you think it is better to use it continuously or discontinuously?
For most patients, intermittently, because then they have for example, no sexual side effects half of the month. So that is much better, and it, as we have shown, as effective for irritability, and in fact very effective. There are very few non-responders to that. Some patients that may prefer continuous because they have some symptomatology also in follicular phase, but for the majority, I think intermittent treatment is preferable.
Ladies and gentlemen, join me in applauding our awardee, Elias Eriksson. Thank you.
Thank you.